Good day to everyone, and I would like to welcome you to the 30th Annual International Medical Fitness Association Conference. My name is Kendall Noble. I'm a registered kinesiotherapist representing the American Kinesiotherapy Association, and my presentation today will be on methods for training individuals with paraplegia. Just to start off, I have no financial interests or relationships to disclose, as some of the information I have are certain products and devices, so I don't have any contracts. I'm not endorsing anybody, just things that we've been using throughout our practice. So the course objectives will be: one, understanding your patient or client's level of injury and their functional abilities, the ability to identify when your patient or client needs medical assistance or needs to set up an appointment with their medical provider. And lastly, identifying pieces of equipment that are paraplegic friendly, things you could potentially order to have in your facility. Some are high tech, some are low tech. So we'll go over just a few of those as well. So just to get into it, what is paraplegia? Based off the Merriam-Webster dictionary, it defines paraplegia as a partial or complete paralysis of the lower half of the body with involvement of both legs that is usually due to injury or disease of the spinal cord and the thoracic or lumbar region. It describes paralysis as a complete or partial loss of function, especially when involving the motion or sensation in a part of the body. The reason for the second, more generic description is that paralysis can affect many different areas of the body, whereas paraplegia is somewhat limited. So here we have just your paraplegia by the levels: thoracic level T1 through lumbar level 5, L5. As you can see, I have the entire spinal cord, but as you can see how vast and how much it covers if you're a paraplegia in those areas. So going straight through the T1 through the T5 nerves, they affect your muscles, your upper chest, mid back, and your abdominal muscles, some of the abdominal muscles. The nerves and muscles help control your rib cage, lungs, diaphragms, and all the muscles that help you breathe. Your fingers, your hand intrinsics, your intercostals, upper chest, mid back, and you will have poor trunk control. So think about that when you think about a patient. If they have a T2 paralysis, when you're doing certain exercises, you may need to get some type of strap to put across their chest to strap them to their chair, their wheelchair, or whatever piece of equipment you're on, just to ensure their safety, because they don't have none of the functions from that place lower. T6 through T12, they affect the abdominals as well as the lower back muscles. Nerves and muscles are important for balance and posture. These are the intercostals, your upper and lower abdominals, your quadratus laborum, hip flexors and adductors, but you will have normal upper body movement and control and fair to good trunk stability. So these are case by case basis if you would need a patient or a client to strap them down to a chair. Most will have the ability to maintain themselves, or they have some weakness right now, and you can actually create some abdominal exercises or training programs to actually improve that. The L1 through the L5 generally result in some loss of function in your hips or your legs. As you can see, people with injuries to the lumbar have little or no voluntary control of their bowel and bladder. So those are some of the things you need to think about too. I'll get more into that as the presentation goes on, but try to make sure you tell your clients or patients if they need to use the restroom before your sessions to try to do that the best of their ability if they can. Whether even if they have a catheter on, make sure the bag is empty, or if they're doing intermittent catheterizations, which is ICing, where they're able to insert the catheter whenever they need to drain their bladder and go from there. And like I said, depending on the strength of the legs, the injured person may need a wheelchair, or they may be able to just walk with bracing. So on your initial eval, you'll be able to identify these when you ask these specific questions, and you can figure out how to tailor your programs, or you can see what equipment or things they have that can actually enhance what you already set in place for them. And then this is just going out to the sacral, just talking about some of the nerves that we have. Still same with little or no voluntary control of the bowel and bladder, but they still may be able to walk, but it's just a deeper injury. So what should happen first when you have someone that comes into your facility? Upon meeting them, ensure that they have medical clearance from their physician. That's the first thing. First things first is, I know you want to get better, you want to get stronger, improve things. Are you clear from your doctor? And then ask specific questions. They say yes, Based on your level of injury, did your physician make any specific recommendations for you? Did they say what things you can do at this point, or try to work on, or what things you can't do? Or should you have 5 to 6 weeks working out in the gym with the personal trainer, and then you need to come back to the physician so he can do a re-eval? So sometimes physicians will give direct orders of things you can and can't do, different precautions. Identify the level of injury. Again, this goes back to the earlier slides, so you will know what you are working with when you initially see this client, and then any blood pressure issues. This too will be detailed more throughout, but however, have your patient ask these questions. Do they know what their normal range of blood pressure is? Do they have certain triggers that will give them lightheadedness or things of that nature? The benefits to exercise post spinal cord injury: improve breathing, muscle strength and endurance, circulation, which is a key, as being paralyzed, par- parts of your body you aren't moving as much, so therefore you don't have a lot of blood flow because of the weakened muscles and all that going on. So being able to move around is paramount to ensuring circulation is key. Body composition, self-esteem and self-confidence, that's a big one, as people, that's a drastic change in their lives, from going ambulatory to either temporarily or permanently in a wheelchair. Your life has changed as you know it, so you need to figure out things that can get you back in the groove and get you back moving. Depression, anxiety, it can improve it, or that also will come into play, which is with the self-esteem and self-confidence. Improving your independence level, being able to be modified independent to independent with your quality of life and functional mobility from a wheelchair level at home. Being strong enough to do these things. You're more efficient in your daily tasks, have more energy, and being able to maximize and maintain your positioning. So being your position is one of the key things you need to work on. Position and form, especially when you're sitting in a wheelchair, because that can affect other muscles and things of that nature while you're in your chair. The impact on the ability to exercise: blood pressure difficulties due to the lack of muscle return, being able to change in pulse for individuals with injury levels of T6 and higher, as it's difficult to access the cardiovascular fitness, and then temperature regulation. And we'll say, so going back to the first one, the blood pressure secondary to lack of muscle return, you have to think about the solutions. You're sitting in the chair, you're paralyzed, your lower extremities, you have no innervation, they're just there. You have difficulty with your blood circulating throughout your whole body. So you would do different things to improve these. They will have different types of abdominal binders or lower extremity wraps, TED hose, stockings, something that can give that compression to assist with everything going around. Change in the pulse. Patients will have different type of orthostatic hypotension. That also goes back to blood pressure. If your hypertension is basically the drop in the blood pressure, you may get lightheaded, you may get dizzy, you may get nauseous. So being able to understand that and check it before it happens. The change in the pulse is the sympathetic reaction, the body response to the stress, whether you're sweating or you have an increased heart rate, some internal response. That's with a typical quote unquote non-SCI individual. If you have a spinal cord injury, specifically if you have level T6 or higher, you're unable to have those natural body responses all the time. So you have to utilize different types of testing to rate your cardiovascular exercise. Case in point, perhaps using the RPE scale, the rate of perceived exertion. And then temperature regulation, sweating and temperature control rely on the autonomic nervous system. So we just have to ensure that they dress accordingly and maintain a cool environment. Some of the precautions we have with exercise and SCI is skin breakdown and shearing forces. So think about this when, for shearing forces, if you have a patient or a client and you have them in their wheelchair and they're transferring from either their wheelchair to a device, if they're transferring to a new step or some cycle, transferring to a bench, you have to think about the body shearing when are they getting enough lift, getting enough clearance from their chair to whatever device they're shifting on, ensuring that their skin is not compromised. Make sure they do pressure reliefs. They're sitting on their bottom all day. You have to be able to get up, lift some of that pressure off. So one key that we always use in the therapist world is every 20 minutes, they would get at least 2 minutes of pressure off of their bottom. So you have to ensure that that's built into your program, because you don't want to have a patient you're working with them for 45, 60 minutes and they've been sitting on the bottom the entire time while doing strenuous exercise. That could create a big issue. Overuse injuries, especially in your hands and shoulders. When you think about these new programs, limit using too much of one muscle or one motion due to the new limitations based on their level of paraplegia. Case in point, in a manual wheelchair, we're consistently propelling. So that whole arm motion with your biceps and your pecs and your hands and wrist muscles, that is a constant movement. So we may not want to create a program focused on that all the time, because that's consistently being used wherever they go. Medications. If these patients are on medications, ask them what kind they are. Are they narcotics? Are they some type of medication that decreases their pain threshold? It diminishes the pain response. We don't want to have the no pain, no gain. We're focusing on exercises and corrective things that will decrease the pain. And then we want to monitor their posture or form or their facial expressions when they're doing these things. We don't want to sit there and force them where they're awkwardly contorting their bodies or being out of position or form because the weight is too much or they think this is how it works. We're there to ensure that they're doing things the correct way. And then machine safety and injury, just knowing your limits when you're using the machines, having safe surroundings. As a trainer, make sure you're there to spot your client if you may need assistance with it. Grab another person, make sure it's free from clutter or any excess items, and ensuring safety and locking prior to any transfers to the machine, whether it's a slide board being needed, if the board is in the correct place, if your hands are in the right place, and if you as a trainer are in the correct place. All those need to come into effect when you're working on these different machines to ensure safety. One of the biggest things we have with us is autonomic dysreflexia. And autonomic dysreflexia, make sure you know your body's response to a stimulation that might be painful or cause any irritation. So as you can see, it's a potentially life-threatening medical emergency that will affect any patient with a spinal cord injury T6 or higher. They're very rare, but they are common not common, but there are some cases of a T7 to T8 actually developing AD, but for the most part it's T6 and above. So the key to this is knowing your patient's baseline blood pressure, what are their triggers, and what are their symptoms. So those three things need to go back to your initial evaluation examination of your patient. If they're paraplegic, add this into your template so you can always remember it. Blood pressure wise, what's your baseline? We need to know these things. Some of the causes of these are just some irritant below your level of injury. So the typical person, if I'm sitting in a chair, I'm a T5 paraplegic and I'm sitting in my wheelchair all day and I have not done any pressure reliefs. If I did not have any spinal cord injury and sitting in a chair for a prolonged period of time, your bottom becomes sore. You start to feel uncomfortable, feeling easy, and start rocking left to right. Your body lets you know something is going on. If I'm a T5, I don't have that normal sensation anymore, so I won't know. So your body will go into all these secondary alerts to let your body know what's going on. So it's just telling you, I need to do a pressure relief, or it could be your bladder. It's the irritation is blocked, it's filled. You may need to cath yourself, like I mentioned earlier, intermittent catheterization, or your catheter is just kinked and clogged up and you just need to straighten out the tube. They may need to have a bowel movement or other different things. If they may have, like I say, ingrown toenails, anything that can affect you where your body won't get the response based on your level of injury at this point. And some of the symptoms: pounding headache, flushed face, red blotches, sweating profusely. It will be, you can tell the difference between working out sweating and when they're going through AD. It will be very noticeable. These patients will continuously start sweating. Nasal stuffiness, nausea, bradycardic, low heart rate. They'll get goosebumps, clammy skin, and they will tell you if they've had it before or if they have not had it, the way it feels when it comes on, they'll tell you something is not right. Something is not right. And if it is suspected, first thing you need to do is sit the patient and raise their head up 90 degrees, lower the legs if you need to do so, loosen up any tight clothes. That can be the trigger to the entire thing. They may have on sweatpants that are a little bit too tight and they're constricting them. Loosen those up, make sure you have them hooked up to a blood pressure monitor so you can monitor what's going on. Blood pressure readings 20 to 40 milligrams of mercury higher than their baseline would be a key as well. But just make sure you find that stimulus. as fast as you can. But if you see that you've done the most you could, you make sure that their clothes are loose, their feet are elevated, um, they don't have a bowel movement. Call 911 if the symptoms persist. We can just take them to the emergency room where we can get that addressed immediately. So the exercise prescription after a spinal cord injury, working on the mode, intensity, duration, and the frequency. So the mode, just exercise or activities that lack excitement. We need to make sure we have some mundane. We don't want to have a mundane program where it's boring. We're doing the exact same thing. They don't want to continue this. They don't want to keep doing the same monotonous thing every day. Let's change up our programs. Identify different activities that will hold their interest on a consistent basis, as that would improve their long-term compliance with the programming. Have the ability to provide resources and equipment that are reasonably cost, because that will play a factor as well. And then identifying cost-effective equipment to maintain the spark of independence once they're cleared from you as a trainer. So case in point, being able to have TheraBands, grasping cuffs, little hand weights, things that they can have at home so that they feel more enthused to actually start things, have more initiative to do things at home on their own. In terms of intensity, so the research states that women have between 50 to 80% of your peak oxygen uptake is sufficient to improve your fitness and reduce cardiovascular risk. So a couple ways that you can work on that is using the talk test or the RPE scale. Talk test is pretty easy. It's basically you just need you're talking to your client while they're doing their exercises, and you just want to make sure that it shows they're exercising to a level to maintain a conversation, but they're not short of breath every 2 seconds. So they're not saying I'm okay. Yeah, we don't want to hear that. That's when it's a little bit too much. You need to take that back where they can hold a normal conversation, but you can see that they're breathing a little bit. Or we can also use the Borg RPE scale. You have the modified, which goes 0 to 10, or you have the traditional scale, which goes 6 to 20. And that is something that we want to have people floating around. With the modified Borg scale, between 3 to 5 is typically okay, 3 to 6 maybe. And with the traditional Borg, we'll stay between the 11 and the 15 range. Anything higher, the patients will complain. They won't get what they need out of it, and that's when they start to push themselves a little bit too much, and that's when their posture may change because they want to make sure they get this rep going and they start contorting their bodies and things in that nature. Frequency and duration. ACSM, their recommendations are always 30 to 60 minutes of physical activity 3 to 5 times a week. Just add in for the spinal cord injury, the dysreflexia awareness and temperature awareness, things we just talked about, autonomic dysreflexia. So make sure they empty their urine bag or AIC, intermittent catheterization, and just draining the bladder prior to exercise. Their heart rate changes in tetras and quads that may not show the same response as our paraplegic. So we have to be able to understand what's going on and what's the difference between those. And then also exercise sessions should include short bouts of 5 to 10 minutes of moderate intensity, alternating with active recovery periods of 5 minutes. And just remain cognizant of upper extremity overuse, secondary to all the functional activities such as wheelchair propulsion. And then we jump over to our exercise program components. We have our cardiovascular conditioning, aerobic exercise, our respiratory endurance, strengthening, muscular strengthening, endurance, and then stretching and flexibility. So some things we can do cardiovascular conditioning wise, the one we've been talking about all day almost, the wheelchair propulsion. You can have patients propel around the track in your facility if you have it, indoor or outdoor, and that can be their aerobic activity for a while. They can do seated aerobics. They have different classes, different online courses that you can take and download and have those clients perform those under your watch, using an arm ergometer, whether it's the upper body arm ergometer where it's cycling, or you're using like a ski ergometer where the patient is actually doing that as well, either thing to get the upper extremities moving. And we also have some clients that are into swimming and are able to swim as paraplegics. And then on the other hand, the super activities in terms of sporting, we can do wheelchair rugby, wheelchair basketball, softball, and boxing. That's just to name a couple, but they have an entire array of those, especially in the wheelchair games. So those are things that you can help train your clients for so they can do to enjoy or understand where they are as paraplegic and improve themselves. Things for the respiratory, endurance, and strengthening. So the SCI has a negative effect on your breathing. You have inefficient or decreased inspiratory muscles. So you have a few types of respiratory training, but you make sure you're increasing your vital capacity and you're improving your inspiration and expiration speed. So one exercise you could do is have a client take a deep breath, holding it for a few seconds, and exhale slowly through pursed lips. That can assist with increasing your vital capacity, but you need to make sure you avoid your hyperventilating and avoid performing until you have a headache or you have shortness of breath. Another example would be taking a deep breath, taking it as much air as much as you can, as fast as you can, and you're exhaling as fast as you can. Just that's the one that's improving your speed of inspiration and expiration. Muscular strength and endurance. I mean, that's our backyard. We can work on free weights. We can do the bands and the elastics, the wall weights, the machines. We have all of these. Those things are in our wheelhouse. Just remember, starting out with these patients, start off with low weights, 3 to 5 sets, 10 to 15 reps with a moderate intensity. You have to monitor their quality of movement, ensuring that their posture and form is not compromised, especially with this population. If you have patients where their form is compromised, that may induce some type of shearing force or some rubbing where they may mess up or open up their skin. So we need to be able to control it. If we need to drop the weights down more just to work on the form without even touching the weight, then we can start that way and build our way back up. Have to prevent these painful positions, and then prevention of your overuse injuries. And then when you have a patient with paraplegia, these are the muscles that you should focus on. Your shoulder depressors, assist with transfers and pressure reliefs. Your shoulder extensors, helping with manual wheelchair propulsion. Your shoulder external rotations, they stabilize the shoulder because once you're sitting in your wheelchair, normally your hands are resting on your lap and they're sitting, you're more so in a internally rotated position in both your shoulders. So being able to do the external rotation to open that up, that will be one of the great ones for you. Scapular retractors, in terms of posture and pulling motion, and also your triceps. Stretching and flexibility that counteracts the tightness related to sitting posture and positioning. So being in your wheelchair 7, 8 hours a day in the sitting, your hips, knees, and ankles all flexed. You have to work on stretching those out throughout the day to ensure that you don't get stuck in these areas. So make them gentle, long, prolonged, 20 to 30-minute stretches, and make sure you're breathing appropriately. And you're doing these daily. Few of the muscles that you may need to stretch on a daily: your upper traps, your pec major, pec minor, biceps, and then your posterior capsule of your shoulder. Those are areas that we need to touch because if you're in a wheelchair, you have to think about how your position is. You want to alleviate or eliminate getting these rounded shoulders. You want to have your chest up, shoulders back, shoulders down. You don't want your shoulders touching your ears. There, you got some tightness in your traps. We need to work on those. Those are all things you need to stretch to ensure that everything is going well. And then moving on to our equipment, right here for its very low tech, inexpensive grasping cuff. These are things that you can see with the picture to the right. You strap it onto the patient if they have poor grip, and you can actually just hook it onto whatever exercise you need, and you can have them doing this. As you can see, we have these with a lot of our patients in the hospital, but this is something that's very inexpensive. The next one is just a functional hand weight. In therapy wise, these go up to 2 pounds only. However, I've seen other ones outside of the typical vendors that come to therapists that have higher weighted ones, but these are the ones you would use if you're just starting with a patient and they're very, very weak using these, or if you're doing aerobic exercise, you can have a 1 pound hand weight on both hands and have them doing arm circles or overhead reaching or shadow boxing. Those are some things that they can do with that where they're still getting a little bit of weight, but it's still improving. Some things that you can have in your gym for stretching: a reach and range overhead pulley. You can hook that to any door frame or anywhere that's sturdy and secure. Have your patient wheel under it, and they can just work on working on the shoulders flexion, shoulder extension. You can do some shoulder abduction, adduction, just stretching it and holding and getting that body open in the position that you need. And we can't neglect our lower extremities. I know we're working on strengthening and stretching our upper extremities. However, we can get our patient and our clients on that mat and put this TheraStretch strap on them to have them stretching their lower extremities. We need to ensure that those are staying loose and limber at all times. Because in times, if you do not stretch it and your body gets stiff, you have a lot of spasms and contractures that could potentially limit your comfortability sitting in your wheelchair. And that's things we do not want. This is everywhere. We have our TheraBands. Those are 1,000,001 uses right there. And then also we have our rolling wrister, which is simply just working on building up forearm strength. Attach a weight down and just have the patient doing wrist roll-ups. They can sit in their chair. They can do this at home. This is something that you can give in a home exercise program, very inexpensive. We have our Physio Max body trainer, which is a little bit more pricey. However, you can, as you can see the chair, you can slide the chair back and you can actually roll your wheelchair up to it. And right here, you can work on upper extremities and lower extremities. You can actually put the feet in there and strap them in, and you can work on both settings. And this goes actively where the patient or client is doing everything on their own, or you can have passively where the machine does it for them. And the one on the right is a Monarch rehab trainer for upper extremity, like an upper arm ergometer. Those things you can set on a table, set on a countertop, strap it in, lock it down, and just have the patient rolling, loosening up those upper extremities. Now, one of the big boys is an MX4 multi-exerciser. As you can see, this entire piece of equipment is for manual wheelchairs, and it has a multitude of different exercises. You got your chest press, your mid rows, your lat pull downs. You have a lot of exercise you can do, and it's specifically for a manual wheelchair. These are 2 cycles. The one on the right, the TheraCycle, is strictly for lower extremity use. Same thing, this is a completely passive range of motion cycle where you will strap the individual's feet into the pedals, set the parameters and settings that you would like, and it goes on its own. So you can continue to maintain that cycling motion and stretching out your lower extremities. The ACP OmniCycle Elite is the same, however, it's upper extremity and lower extremity. And it has different settings, different functions, different biofeedback. If you have a client that does have paraplegia, but they do have some strength in their lower extremities, they can use this cycle, the OmniCycle Elite, and you can add resistance to it. It has different settings where it gives you biofeedback to where you can see, okay, I'm using my right leg a little bit more this week, and you can tailor programs for this cycle itself. It has the 2 hooks under it so it can secure the manual wheelchair so that it does not move or rock while you're doing these exercises, which also limits any friction forces with that. Here's a few of my sources I got my information from. And I would like to thank you all for taking this time out to listen to me. My email is there if you have any questions, kendall.noble@va.gov. And that's it.